So today I'm going to talk a little bit about heart involvement in myotonic dystrophy. Most of my comments are actually going to be related to myotonic dystrophy type 1 because our study requires patients to actually have myotonic dystrophy type 1. I will tell you that in general, patients with myotonic dystrophy type 2 have very similar disease problems with the heart that the patients with myotonic dystrophy type 1 have. It typically occurs, however, later in life, whereas sometimes the problems in myotonic dystrophy type 1 can occur, in young adulthood or in, mid-adulthood, typically age 30 plus is where we really start to worry about the problems. I want to recognize that the data I'm using and what we're talking about today is from our study called the Arrhythmias in Myotonic Dystrophy Registry. This is a study that included over 400 patients with myotonic dystrophy at centers throughout the United States, and this work was supported by the Arrhythmias in Myotonic Dystrophy investigators who helped us recruit these patients. We did receive funding from the federal government with an NIH grant, and that's listed on the top of this slide here. We have received funding over the years from the Muscular Dystrophy Association, and we also received funding from a company that makes pacemakers and pacemaker defibrillators called Myotonic, and they helped us to fund especially some of the early parts of our study. So again, I want to make sure that you all recognize that this is areas that if we didn't have financial support for some of our work, we wouldn't be able to do this. Leslie, next slide, please. So it's not peculiar to myotonic dystrophy to have heart abnormalities. We do know that other muscular dystrophies do have significant heart problems. Duchenne and Becker muscular dystrophy, this is the X-linked recessive muscular dystrophy that typically occurs in young men, and this can lead to heart problems, more of a pump problem than the electrical problems we'll talk about. Of course, we're going to talk today about myotonic muscular dystrophy. There's several other muscular dystrophies, including Emery-Dreifuss muscular dystrophy, limb-girdle muscular dystrophy, and facioscapulohumeral muscular dystrophy that can lead to heart problems. Some of the non-muscular dystrophies that are neuromuscular disorders can also lead to heart problems. That includes Friedreich's ataxia. And then there's some rare diseases that are primarily problems neurologically, but that also lead to heart problems. These include, again, these more rare diseases called the periodic paralysis, mitochondrial myopathies, or also called mitochondrial disorders, spinal muscular atrophy, a non-inherited disease called Guillain-Barré syndrome, and myasthenia gravis. Next slide, please. So let's make sure that we're all on the same page in terms of myotonic dystrophy. Myotonic dystrophy, we as researchers describe this as an autosomal dominant neuromuscular disease. That means that typically it's passed from generation to generation, and because it's an autosomal dominant, if someone has the disease, the likelihood of passing it on to one of your offspring is 50-50. And we know that it's named actually for the myotonia, which is the delayed relaxation of muscles. And this can be a reflex or a percussion myotonia, meaning reflex, this is after a reflex occurs, or percussion, meaning that if the muscle is tapped, you can see, again, this contraction of the muscle. It continues on with weakness and progressive atrophy of skeletal muscles, and that's why patients with myotonic dystrophy tend to have weakness in their muscles. Usually it starts with we call the distal muscles, or farther away from the central part of the body, and then spreads more to the proximal muscles. Now, myotonic dystrophy is a systemic disease, and some of the systemic side effects would be early balding, cataracts, and heart involvement. And as I said earlier, myotonic dystrophy type 2, which is a specific genetic disease, tends to cause more heart involvement than myotonic dystrophy type 1 tends to cause an earlier and typically more severe type of heart problems in type 2. Now, myotonic dystrophy type 2 is the most common of all the adult muscular dystrophies, meaning a disease that presents in adults. And in the United States, we know that the prevalence is about 1 in 7,500 to 8,000 people. Next slide, please. I just wanted to show where we enrolled patients in this muscular dystrophy study. This is information about the sites that were involved, and you can see that we had 25 sites involved in this study with 23 sites recruiting patients, and the patients started to be recruited in 1996. Next slide. So let's talk now about how the heart's affected in muscular dystrophy. Well, the heart, of course, is a pumping organ, and anytime you have a muscle that has to pump, essentially, or to contract, you're going to need a blood supply to it. And so on the left side of this slide, you see the blood vessel supply to the heart. And this is very important because these blood vessels can have disease and problems with them, and this can lead to a heart attack. And a heart attack is when a blood vessel gets blocked off and can't get enough blood to it, and that part of the heart can die. So that's the most common heart problem that we see in people in the United States, but it's not the problem that really leads to the major issues in patients with myotonic dystrophy. So if we go to the right side of this slide, we see that the heart muscle is controlled as well by an electrical system. And this is the signal that spreads through the heart that controls the contraction of the heart. And the heart has to contract in a rhythmic fashion in order to pump the blood out. And this electrical signal controls that. So it would be like a car engine in some ways, where the spark plugs and the spark wires control the cylinders and the firing of that car engine. But in the heart, it's the electrical signal that comes from these specialized tissues. The heartbeat starts up into something called the SA node, or sinoatrial node. It spreads out through the atrium, gets into the middle part of the heart that we call the AV node, and then spreads rapidly through the bundle of His and the left and right bundle branch block that then allows the heart to contract rhythmically. And it's this system and scar tissue that can build up in this electrical system in patients with myotonic dystrophy that seems to cause most of the problems that we observe with the heart. We don't necessarily know especially why these specialized conduction tissues tend to be more affected than the remainder of the heart, but these cells are very metabolically active. They require a lot of oxygen, and if there is stress in the heart related to, in the case with myotonic dystrophy, related to changes in the muscle, that may be why these specialized tissues are affected. We do know that the remainder of the heart can be affected as well, and we call that can be something called cardiac fibrosis or scar tissue building up the heart, but it's rarer in patients with myotonic dystrophy. If the electrical system is affected, then typically the problems that occur are something called arrhythmias or heart rhythm disturbances. If the remainder of the heart gets affected, then the heart can have difficulty pumping, and if the pump becomes dysfunctional, then patients can have something called heart failure. So in our study, we know that the major problem with the heart are arrhythmias, and later on, and more rarely, you can see heart failure as well. Next slide. So when we think about the heart, and I like to think about two separate problems that can occur. There can be problems with the pump or with the blood supply to that pump, and there can be electrical problems. And these might be some terms that your doctor will use, or that perhaps maybe you heard of either in your own heart care or in the heart care of some of your loved ones. So a pump problem, for example, could be coronary heart disease. And again, this is a blockage in the blood vessel. And if it goes to its extreme, it can cause a heart attack. If there's problems with the overall pump, either due to a heart attack or related to abnormalities throughout the heart, that can lead to heart failure. If there's problems with the valves in the heart, that can lead to valvular heart disease. If patients are born with heart problems, we call that congenital heart disease. There are rare cancers of the heart. These are very rare, but they can occur. If there's problems with the lining of the heart, we call that pericardial disease. Now, in terms of electrical problems, the problems that commonly will occur is something called atrial fibrillation, which is an abnormal rhythm in the upper part of the heart, or the atrium. And a cousin of this is atrial flutter, which is another rhythm that occurs in the upper part of the heart, or the atrium. The more serious heart problems are the problems that occur in the lower chamber of the heart, or ventricle, and these are called ventricular tachycardia or ventricular fibrillation. These are problems where the heart doesn't stop beating, but it actually beats so fast that it can't pump effectively. And if it beats too fast, it can't pump blood out at all, and people have a fainting spell, and if they're not treated, they can actually pass on from this problem. So the problem that can occur then, if the heart has problems with the pump that are very severe, or severe electrical problems, is this issue called sudden cardiac death. And that is essentially where the heart stops pumping, no blood is ejected out of the heart, the brain doesn't get blood, people pass out, and if they don't receive care, such as CPR, and defibrillation, people can pass on from that problem. So that overall electrical problem that we call is called arrhythmias. Now, the doctors that take care of patients with these issues are generally a cardiologist, that's just a heart doctor. If there's a pump problem or blockage in the blood vessel, that typically is an interventional cardiologist. And the specialist in the electrical problems of the heart is a cardiac electrophysiologist. And that's what I do. I'm a specialist in these electrical issues in the heart. If someone has heart failure, there can actually be a specialist in that alone. We call that a heart failure specialist. And if someone needs heart surgery, a replacement of a heart valve, coronary bypass surgery, that person is called a cardiac surgeon or a cardiothoracic surgeon. And so those could be all the different doctors related to the heart that you may have to deal with at some point. In general, because the problems in myotonic dystrophy tend to be these electrical problems, the doctors that know the most about that typically are the cardiac electrophysiologists. There may be some general cardiologists who know, quite a bit about this as well. So if you're seeing a cardiologist, you may see that type of doctor. Now, some of you may have an internal medicine specialist, and an internal medicine specialist basically deals with the internal organs, and he may know a moderate amount of information about the heart, and he may be able to use some of the information to evaluate your heart and decide if you need to see a cardiologist or cardiac electrophysiologist. So not necessarily everybody with myotonic dystrophy absolutely needs to see a cardiologist, but the doctor that you're seeing should be comfortable with assessing the heart and knowing the latest information on how the heart needs to be assessed and what would be significant abnormalities that might require further evaluation. And in some situations, your neurologist or neuromuscular specialist may have this knowledge, and hopefully if he or she doesn't have the knowledge, they will refer you to a doctor that does have the knowledge. For example, at Indiana University, I work very closely with the neuromuscular specialist, Dr. Robert Pascuzzi, and some of the other specialists, and we typically work together and provide a team approach to myotonic dystrophy patients and their best care. because myotonic dystrophy, again, is this systemic disease affecting not just the skeletal muscles, but also the heart muscle and other organs, we think it best actually to work as a team. Next slide. Okay, so one of the things that we have figured out was that a simple screening test called the electrocardiogram can be used to determine whether or not a patient with myotonic dystrophy may be at high risk for arrhythmias. And the electrocardiogram is simply a test where they put some special type of electrodes with just like little sticky pads on the surface of your chest, and they record the electrical signals coming from the heart. It's been a test that we've been using in patients to assess their heart since about 1900 or so. So it's really an old test at this point, but it provides a significant amount of information. And what you can see on the slide here is some of the squiggles, essentially electrical signals that we see when we do this type of test. And what you notice on the left side of the slide is something called the P wave, and then the so-called QRS, and then the T wave. And the P wave reflects back to the contraction and electrical activity that occurs in the upper chamber of the heart, or the atrium. And the QRS looks at what's going on in the ventricle. And we can measure these intervals and determine how long it takes for the signal to reach from the upper to the lower chamber. And that gives us an idea about how much abnormality or fibrosis there is actually in the specialized conduction tissue. And I recommend that patients with myotonic dystrophy get an EKG on an annual basis. I think that's knowledge that is fairly widespread at this point. It should be a fairly inexpensive test. It can be done in all doctors' offices. If your neurologist can't do that, he should have a centralized area that he can get this done. And again, not a very expensive test, and it has a lot of useful information in it. And one of the things I think you can ask your doctors too is, what are my numbers? And we found several characteristics from our study, again, over these last 15 plus years, that would reflect a higher risk for patients to have heart problems following, the findings from the electrocardiogram. And so I would say to you, one of the things you may want to do is know your numbers from your electrocardiogram. The two numbers that we're looking at is something called the PR interval, and that measures from the beginning of that P wave, which is the atrial electrical activity, to the beginning of the QRS. And if that's greater than 240, that person's at higher risk of heart problems of multiple types. The second number is the so-called QRS duration, and that's measured from the beginning of that Q wave to the end of the S wave. And if that's greater than 120, that also puts someone at higher risk for potential heart problems. And these are easy numbers to measure on the electrocardiogram. In fact, the computer will actually help measure these. A lot of times the doctor who's looking at this, though, has to remeasure them to make sure it's accurate. This is something I do in my muscular dystrophy patients on a yearly basis as well. Now, if in fact you have these type of findings, your doctor may decide that you need to be referred to a specialist like myself in cardiac electrophysiology. And this is something we call a screening test, meaning a test that can help us determine who might be at higher risk, but not necessarily tell us exactly what to do. So if I see these abnormalities in patients with myotonic dystrophy, I may go on and do some further testing. And in some patients, we may decide based on these type of numbers to actually make a decision to put in a pacemaker or a pacemaker defibrillator. And we'll talk a little bit more about that in a few minutes. One other option is to do something called a cardiac electrophysiological study. And that's where we actually go in and we measure exactly how much time it takes to conduct through the heart by putting special catheters in. These are catheters that actually go through veins into the heart and measure the electrical signals directly. We can also use those catheters to try to make the heart go into an abnormal heart rhythm to see if people might be at risk of that. Next slide. So this is an example of what an electrocardiogram might look like. It's typically on red paper like this, and it has multiple, we call leads, basically, that give us information about different parts of the heart. This is actually an electrocardiogram from a patient with myotonic dystrophy. Excuse me. And based on this electrocardiogram, this patient, I'm just taking a drink of water, excuse me. This patient actually didn't go on to an electrophysiologic study, and later on received a pacemaker defibrillator, so a device that has both of that. What you notice on this electrocardiogram is that initial PR interval is long, and we see extra beats also coming from the lower chamber of the heart. We call those PVCs. Those together, along with that PR interval and some of the other abnormalities, make us more concerned about this patient. Next slide. Next slide, Leslie. Thank you. So this information was, again, in 2008, we had been working on our study for almost 12 years at that point and gathered information about our patients with myotonic dystrophy. And in 2008, we published this paper in the New England Journal of Medicine called Electrocardiographic Abnormalities and Sudden Death in Myotonic Dystrophy Type 1. And we showed that the electrocardiogram and the clinical history could be helpful to determine who was at higher risk of heart rhythm disturbances. And so really opened up essentially this relatively easy screening test and said, this can be used by average doctors to help patients with myotonic dystrophy, and allows us to really carefully determine who is at risk of these type of issues. This New England Journal of Medicine is a very prestigious medical journal. We are very fortunate to get it published in this. The most important thing about this is a medical journal that's read by doctors of all types, including neurologists, including internal medicine specialists, cardiologists, and cardiac electrophysiologists. So it gave us a very good pedestal, essentially, to put out our ideas and to let people read this and see what they thought about it. So we were very pleased about this, and this publication really led to our study being recognized as an important study in determining how to best evaluate and treat heart problems in myotonic dystrophy. Now, based on this study, others throughout the world have actually looked at their patients in similar ways to us and really have replicated what we found. So not only did we find it with our 400 plus patients in the United States, but others have found it with patients in different parts of the world. So we feel fortunate again that that data is replicated, and I think it tells us that this can be useful. Next slide. Now, one other test that your doctor may decide that you need at some point is something called an echocardiogram. And an echocardiogram, and this is just a picture on the left side of someone getting an echocardiogram. An echocardiogram is actually a picture of the pumping function of the heart. This is different, again, than the electrical system. And I recommend that in general, that a patient with myotonic dystrophy, once they see their cardiologist or a cardiologist for the first time, that typically an echocardiogram is done. And this allows us to see, is there any problems with the pumping function of the heart, not just the electrical problem. In general, if someone does not have an electrical problem, the likelihood of major findings on the echocardiogram are relatively low. The other time I do this is if patients with myotonic dystrophy have symptoms potentially related to the heart. What could those symptoms be? Well, for example, shortness of breath, especially shortness of breath with exertion, or sometimes shortness of breath that occurs when you lay down at night. We call that orthopnea. Some patients will have swelling in their legs. We call that edema. So any of those type of things might have us look at the echocardiogram to see whether or not the pumping function of the heart could be affected. We had echocardiograms in the majority of our patients. Back to the echocardiogram slide just for a second. Thank you. We had the majority of our patients in our study have an echocardiogram, and we found abnormalities in the moderate proportion of people, not as high in any sense as in the electrocardiogram, but enough that I would recommend this test in general for people. Now, the one thing is that if you don't have medical insurance, this can be actually a fairly expensive test. And so if you were going to get one test, I would get the electrocardiogram. And some of the findings from this echocardiogram can also be assessed via the physician examination of the patient. Next slide, please. So in our study, we followed patients again for about 15 years, and quite a few patients with myotonic dystrophy at some point needed a pacemaker or a pacemaker defibrillator. And this slide shows how a pacemaker is implanted, and also shows what the pacemaker looks like, and actually on the far right is actually a defibrillator. This isn't quite the same size, but a pacemaker is actually implanted typically in the left shoulder area underneath the collarbone, and it has wires. You can see those wires in the pictures. These wires actually go through a vein down into the heart, and they provide a signal to the heart to start pumping. So they provide an electrical signal if there's an electrical signal problem with the patient's own heart. And again, as we said, in myotonic dystrophy, the problem tends to be with the electrical signal, and therefore these devices can be life-saving if the patient has a severe electrical signal issue. Now, there's some differences that you should understand between the pacemaker and the pacemaker defibrillator. Okay, so the pacemaker only takes care of slow heartbeats, meaning it will increase the heart rate of a patient whose heartbeat is too slow. Now, a pacemaker defibrillator, it also could be described or called an implantable cardioverter defibrillator, has both pacemaker functions, meaning it can help to slow the heartbeat, but it also can help to regulate too fast of a heartbeat, such as that occurs with ventricular tachycardia or ventricular fibrillation. So it has both those functions. Now, there still remains some controversy about which is the best device for patients with myotonic dystrophy. Some people who've done work in this area think that the pacemaker will take care of the majority of issues. Other people believe that because there's risk of both the slow heartbeat and the fast heartbeat, the pacemaker defibrillator or the implantable cardioverter defibrillator is the best device to use in patients with myotonic dystrophy. I can tell you that I still continue to use both, and I try to use the best device I think that would fit for that individual patient, right? So each time when your doctor takes good care of you, he will try to do what's best for you, not necessarily for all of the patients with myotonic dystrophy, but best for you. So when I talk to patients, we go through this together. We talk a little bit about what's going on with their heart. We try to gather as much information. And if I think that they would benefit from one of these type of medical devices, we call them cardiac devices, then we talk about that, and together we make the decision whether or not it would be a pacemaker or a pacemaker defibrillator. Next slide. So I think this may be the last slide. So in summary then, what have we found over the years, and what do we still need to know? Well, we do know that patients with myotonic dystrophy can be at high risk for heart abnormalities, primarily heart rhythm disturbances. Again, we call these arrhythmias. We know that the electrocardiogram, a relatively simple test, can help the managing doctor determine how significant the heart abnormality is, and again, help to make decisions about further evaluation. The electrocardiogram, of course, is a diagnostic test, meaning it helps us know about things, but it doesn't do anything in terms of treatment. So it has to be, you know, if it can be, if the finding on is of low risk, then that can be helpful, saying, you know, we don't think that there's any major abnormalities to worry about at this point. But if it has some abnormalities that we're concerned about, then typically further testing will need to be done. We talked a little bit about the echocardiogram, and I said again that many but not all the patients will need an echocardiogram. And then finally, patients with myotonic dystrophy, individuals with myotonic dystrophy, could require pacemakers or implanted cardiac defibrillators. And in our study, we didn't actually, we observed how patients were treated, but we didn't interfere with that treatment, meaning the patients had their own doctors, and we watched how those doctors treated them, who they referred them to in terms of other physicians, what was done. And in our study, about 10% of our population in the United States received a pacemaker, and about 5% received this implantable cardiac defibrillator. Next slide. I think so. Maybe that's it at this point. So, well, okay. Here we got one more. I guess we can. So what can you do? What should you do in terms of your disease with myotonic dystrophy in the heart? So you should watch for and report any symptoms that could be related to heart disease. Things like easy tiredness, shortness of breath, chest pain, swelling, and fainting spells. People might also have things like palpitations, meaning a feeling of an irregular heartbeat. Now, some of those symptoms may be related to other problems, not your heart. For example, we all feel fatigue sometimes, and myotonic dystrophy can lead to other problems that can cause fatigue or tiredness, such as sleep apnea and you know, just general muscle issues and weakness. I would recommend keeping as active as you can be. We don't see that any of the problems related to the heart and myotonic dystrophy really can be negatively affected by being active. So I would recommend being as active as you can be. These are different problems than the normal heart problems that patients get. Of course, things that we all try to do, like watching our diet, making sure we know what our cholesterol is, can be helpful for you as a person with all the same heart problems that people can get as well. Again, but those type of things like diet, cholesterol levels may not necessarily really affect the myotonic dystrophy on the heart. I would recommend that you be proactive about asking your doctor if checking an electrocardiogram or seeing a heart specialist would be helpful for the overall team approach to keeping you healthy with myotonic dystrophy. I would recommend, again, following any heart advice that your doctor gives, but make sure that you are as well your own best doctor, meaning you have to read about these issues and kind of understand why the doctor believes this has to be done. I can tell you that many times when I see patients with myotonic dystrophy, if we do the electrocardiogram and everything looks good with the electrocardiogram and my exam is good and the patient doesn't have any further symptoms, I may just see that patient back in a year and say, at this point, your heart health looks good. So not everybody needs a pacemaker with myotonic dystrophy. And we do know that as people get older, the likelihood of needing a pacemaker may be higher. I can tell you that in our study, it's very rare for patients in the age 20 to 30 to need a pacemaker. The most common age for a pacemaker is at about age 50 plus. I have to tell you one other thing too, and this is under point 5 here, in terms of continuing to support and be an advocate for research in neuromuscular diseases. The more I study and the more we work with myotonic dystrophy, sometimes it seems the less we know. Although we've really done a good job, I think, with our study and getting this information, there's still a lot of questions that are unknown about the heart care in myotonic dystrophy. One of the questions would be, if someone has an abnormal electrocardiogram, should they at that point receive a pacemaker or a pacemaker defibrillator? Are there other tests that we can do to assess them? And we, at this point, are considering starting another study looking at, again, the higher risk patients to determine exactly how best they can be treated to prevent disability and future problems. This is a study, in fact, that may be run at North American sites, including Canada and the United States, and we hope to work as a team with patients with myotonic dystrophy, neuromuscular specialists, and cardiologists interested in this problem. So it remains, again, quite a bit of uncertainty exactly how best to treat some of these issues, and therefore I think we have to continue our hard work of doing good research, and the goal of that is actually to help patients with myotonic dystrophy. Next slide.
I think that will be right. Okay, we're ready for questions. Are you ready?
Okay.
We have a number of questions, Dr. Groh, and
okay.
A couple of them are related. One here, somebody asks, what are the signs that indicate it's time for an ICD? And someone else asks, does an ICD help with PVCs? Okay,
sure. So when someone has signs, so when patients deal with a doctor, a lot of times we talk about symptoms. That's what a patient feels, and signs, that's what the doctor sees. And it's really hard to know exactly what the sign would be for a defibrillator to be implanted. One of the signs would be if someone's actually had ventricular tachycardia before, meaning they've already proven they can have this most severe heart rhythm disturbance. Then we would consider a defibrillator almost for certain. Okay, so that would be one of the signs that we would do that. Our data would say that if the electrocardiogram showed significant conduction disease, that might be a sign where you'd want to put the defibrillator in. Some doctors, including myself, may say, well, the electrocardiogram provides very good screening information, but we need to look a little bit further. And that's where we might consider this electrophysiological study. And that electrophysiologic study allows us then to carefully determine where the problem is in the heart and whether or not the person has a higher risk of arrhythmias. And at the end of that study, we may make a decision and say, hey, we don't see high-risk findings at this point. I would wait to put a pacemaker or pacemaker defibrillator in. Now, the question regarding the PVCs and the ICD. The purpose of the ICD is actually to treat the most catastrophic problems with the heart, that being ventricular tachycardia and ventricular fibrillation. PVCs are just a single beat that occur that come from the lower chamber of the heart or ventricle. And in general, the defibrillator ignores those beats, so it won't really do anything about that. Now, if someone has very symptomatic PVCs, sometimes we have to add medicines to the treatment with the defibrillator that can actually help to get rid of those PVCs. But in general, the defibrillator does not help to get rid of PVCs.
Okay. Does a pacemaker improve energy levels?
That can be variable. Remember, the only thing a pacemaker can do is to increase the heartbeat. And in general, most of us have a good enough heartbeat that can lead to enough pumping of blood outside, into our body that will keep our energy level good. And that heartbeat can be variable, anywhere between really about 40 beats a minute and about 100 beats a minute. So there's a wide variety of a normal heartbeat. So if that heartbeat's in the normal range, the pacemaker won't necessarily make you feel better. Now, if you've had a problem where your heartbeat becomes very slow because of these conduction abnormalities, and that's something called complete heart block, then in general a pacemaker will make you feel better. But that type of problem, that complete heart block, typically kind of presents with almost a catastrophic type problems, fainting spells, and sometimes, again, severe problems that everybody would recognize. It's more rare that the only symptom that people have is fatigue. So it's kind of a difficult question about answering whether or not tiredness or fatigue will be helped. There are some patients who have something called sinus node dysfunction, meaning that the heartbeat doesn't appropriately go up with exercise. Those patients may feel better with a pacemaker. I can tell you that I have a lot of patients I follow with myotonic dystrophy that have a pacemaker, and some of my patients feel better, some do not. There are, again, several issues that can cause fatigue and tiredness in patients with myotonic dystrophy that are separate from heart rhythm problems.
Mm-hmm. Okay, someone asks if ablations are helpful.
Mm-hmm. So ablations, so let's talk about what an ablation is. So something called a radiofrequency ablation is where when someone has rhythm problems, we can put catheters up into the heart and we can find out exactly where that abnormal heartbeat is coming from. And we do that using multiple different techniques. And we then go to that area where the abnormal heartbeat's coming, and we can deliver a little bit of heat energy to that area of the heart. And that stops that abnormal electrical signal from coming through, and can be curative of that arrhythmia. So in myotonic dystrophy, I have done quite a few different ablations. But in general, the patients who need ablation have already had a pacemaker or a pacemaker defibrillator installed, because the ablation will target one type of arrhythmia, but will not deal with the overall arrhythmia environment or picture that is seen in that patient. So we can definitely treat that. So different diseases or arrhythmias that might undergo ablation include atrial fibrillation, atrial flutter, atrial tachycardia, ventricular tachycardia, and those and several other diseases as well. And those all can occur in patients with myotonic dystrophy. So that ablation therapy, again, can be helpful, but in general will not substitute for the need for a pacemaker or a pacemaker defibrillator.
Do you see problems with contractility and heart strength with the DM patient?
That's a good question. In general, it's not the most common problem, but it does occur. So I can tell you that in our study, we saw about 2% of our patients with myotonic dystrophy that had severe heart failure, meaning their heart muscle was weak and there was no other cause found other than the muscular dystrophy, the myotonic dystrophy. So it definitely can occur. About 10% of our patients had evidence of decreased function of the pumping of the heart, the contractility. So, but only about, again, only about 2% of those were symptomatic. So it can definitely occur. Typically, it occurs after the rhythm problems occur and after the conduction system problems occur. Again, problems with contractility or the pumping function of the heart can be determined based on the echocardiogram. And again, I typically will do that test in patients just to make sure that that this is not an issue that have occurred. It's something also that we have to follow up over time, meaning that sometimes patients present first with rhythm problems and then later on will have contractility problems. I can tell you there were several patients in our study, for example, that initially received a pacemaker and then had contractility problems and got a pacemaker defibrillator, and then had problems later on that required them to be on significant types of heart failure medicines. So again, not typical of most patients with myotonic dystrophy, but definitely seen, and something that your doctor has to be able to recognize as well.
Okay, here's a question. How do you define higher risk, irregularity rhythm, or conduction delay, or previous events?
Okay. So higher risk for heart rhythm problems in myotonic dystrophy. One, if you've had previous heart rhythm problems, meaning if you've had ventricular tachycardia before, you're at very high risk for recurrence. If you've had heart block, meaning if you've had to have a pacemaker put in because your heartbeat was not getting from the upper chamber to the lower chamber, the pacemaker will help you with that, but you still have problems with other types of heart rhythm problems, and that would put you at high risk. Two, if you've had problems with the upper chamber arrhythmias called atrial fibrillation or atrial flutter, that puts you at about a 3-fold higher risk than other patients with myotonic dystrophy. 3 times as high risk of, again, these serious heart rhythm disturbances that can lead to problems that can cause you to faint or pass on from the heart. And then 4, the electrocardiogram and the findings that we saw, the PR interval greater than 240 or the Q restoration greater than 120, or the presence of what we call non-sinus rhythm. Again, that would be atrial fibrillation or the presence of a pacemaker. So all of those things can put someone at a higher risk for heart rhythm disturbances. If anybody has those type of findings, they definitely should be seen, I think, by a cardiac electrophysiologist who's really very knowledgeable about how the heart can be affected.
Is it common to have heart palpitations after eating a meal?
Not necessarily. Some patients with problems with digestion and stuff, the meal can actually, a big meal especially, can put some stress on the heart, and they potentially could have some problems with palpitations. In general, most people, if they feel palpitations, will often feel it when they're resting. So for example, as they're going to bed at night, they may feel just that extra beat sensation because the rest of their body is so quiet, they can pay attention to that sensation. Many times people feel palpitations as an extra beat that occurs because when the heart has an extra beat, the next beat after that is delayed, and that beat, the heart will pump very hard. And I think that's the sensation that people commonly get. Some patients have serious heart rhythm problems, and never feel any palpitations or feel anything at all, hardly. Some people have just one extra beat or two extra beats, an hour, and they feel severe palpitations. So the presence of palpitations itself is definitely a symptom that you want to talk with your doctor about, and it should be evaluated, but it doesn't necessarily always mean that something serious is going on.
Okay, we do have a few more questions. They're pouring in. How effective do you feel defibrillators and pacemakers are in preventing sudden cardiac death?
Well, we know that in our, and let me reflect back to our data. In our data, pacemakers were moderately affected, but we still saw some sudden cardiac death. And this could be related to the fact that they only treat the slow heartbeat, not the faster heartbeat. Now, we do know that the defibrillator should be nearly 100% effective in treating the heart rhythm disturbances associated with sudden cardiac death. However, one thing we know is not all sudden cardiac death, not all sudden related death is related to heart rhythm problems. People can have other problems, and we may not know exactly what those are, but that could lead to death as well, and it could seem as a sudden death. Let me give you an example. If someone has a defibrillator in and they have some kind of catastrophic malfunction of their aorta, for example, in an aortic dissection, the defibrillator cannot do anything about that. They would have major bleeding out of the aorta, and they would die quite suddenly, and the defibrillator would try to treat the rhythms associated with it, but it couldn't do anything about it. What we have seen in our study actually is we've had several patients in our study who've had defibrillators in, and they have passed with what looks like sudden death. And we actually had the opportunity to actually check what the defibrillator saw during this time. And in several situations, there were some heartbeat disturbances that the defibrillator really couldn't do anything about, and tried to do something about early on, but then was unsuccessful, actually. The patients that had this happen, unfortunately, also had, not only did they have the rhythm disturbances, but they also had a weak heart muscle. And so if the pump itself can't work and recover, the shock from the defibrillator or the treatment from the defibrillator cannot do anything to get the heart restarted. So in general, I would say that the pacemaker is moderately successful in treating sudden cardiac death in myotonic dystrophy, and I think the defibrillator has high success rates, but there's always going to be situations where someone could pass on, and we might not know what caused it, essentially. Mm-hmm. Unfortunately, too, we all end up having some problem at some point that's going to cause our heart to stop. We all have something causing us to pass on at some point, be it old age or pneumonia, and in the end, the heart has to stop. So again, defibrillators can help, but they're not able to do everything for everyone. My recommendation most of the time at this point is if someone needs a cardiac device, in general, I'm recommending a pacemaker defibrillator in patients with myotonic dystrophy because it can protect from both types of heart rhythm disturbances.
Okay, I think this will be our final question.
Okay.
Is mixilotine safe for DM1 patients to use if there are no heart problems, but it is being prescribed for muscle stiffness and chronic stomach aches?
Right. We could spend another hour talking about drug therapy and whether or not it's safe or not. So here's an interesting thing. So mixilotine is actually an arrhythmia type medicine. It's an anti-arrhythmia medicine, meaning It's a medicine that I've been using for many years. And it's only recently that neurologists have recognized that this might be helpful for some of the myotonic symptoms. I know that the work done through the Rochester group is excellent work. I think that if a patient has no evidence of heart problems, that in general mexilotine can be used safely. What I worry about more is that the heart problems can be progressive, so that if the mexilotine is safe, in 2012, will it remain safe for that person in 2014? I do know that in general, if someone is treated with mexilotine, I would definitely recommend that those patients are being followed with a team approach, meaning the neurologist or neuromuscular specialist and also the heart doctor is seeing them. I have some of my patients on mexilotine. It's helped them. I work closely with Dr. Pescuzzi when those patients are, and we follow those patients even more carefully from a heart standpoint than we normally would do. I typically will see those patients about every 6 months or so. We actually have one of our patients who actually has a implantable cardioverter defibrillator that's on mexilotine, and has helped his muscle symptoms because he's being protected by the defibrillator from the arrhythmias. I worry about him less than I would be for someone who's not protected. So it's a tough question. I think there's a little bit of controversy yet about mexilotine. I'm very impressed with the work that the Rochester group have done and what they're continuing to do, and I think they're being very careful. And my only caveat would be that we should continue to use it very judiciously if you're going to use mexilotine, and use it only in the right patients.
Thank you so much, Dr. Groh. It's been, I really appreciate you addressing all of these questions, and there have been a number of them, and it was a wonderful presentation. Thank you.
No problem. I appreciate it. Our work, we continue to try to work carefully to make sure that patients with myotonic dystrophy get the absolute best heart health that they can. Many doctors don't recognize heart problems in myotonic dystrophy, and I think it's led to problems in providing the best care. So we're trying to continue this recognition that the heart can be affected in myotonic dystrophy, and that the heart deserves to be well treated and carefully assessed as well, to make sure that people can live as long and productive of life as they can. So thank you so much to everybody who's participated. And Leslie, I really appreciate the opportunity to do this, and we'd be happy to do it in the future.
Oh, thank you very much. I'd like to just remind everyone before we close that MDF has a warm line feature. You can fill out a form on our website, and you will receive an email. It's a short survey about this webinar series. We hope you will fill it out. Take a few moments and fill it out. And we hope to see you next month. Thank you.